Hello. Today, I will be kickstarting a new series on YouTube on rare skin cancers. And the first topic that we will speak about will be Dermatofibrosarcoma protuberans, or known as DFSP. Now, why did I choose this topic? It's because in the last few weeks, we have seen or heard of a few cases, and I think we need to be more aware about this condition. So what is DFSP? This is the most common cutaneous sarcoma with an incidence of about 0.5 to 1 in 100,000. Most cases are found in middle-aged adults, but it can also present at birth or in children. A pigmented variant known as Bettner's tumor can be seen in Black patients. What is the etiology of DFSP? In terms of the molecular side of things, there is a reciprocal translocation T1722Q2213, or a supernumerary ring chromosome composed of hybrid material derived from T1722. The T1722 translocation fuses the PDGFB gene on chromosome 22 with strongly expressed collagen 1 alpha 1 gene on chromosome 17. This causes constitutive production of the protein, post-translational processing with functional PDGF-beta, as well as autocrine stimulation of the tumor's own PDGFR. It can also arise in scars due to previous trauma. In terms of clinical findings, DFSP is a slow-growing tumor, and it is commonly found on the trunk and proximal extremities. It is less likely on the head and neck. Usually, a DFSP is asymptomatic. The following are the clinical findings of the various types of DFSP. So firstly, it can present as a plaque, which is firm, indurated, and skin-colored, with nodules which are red, brown, and exophytic. This is the most common presentation of DFSP. It is initially mobile and later becomes larger and adherent, and you can also find in these cases tint epidermis and telangiectasis. Uncommonly, there can be bleeding or ulceration. A less common presentation is a non-protuberant atrophic violaceous lesion. This can resemble morphea or sclerosing BCC, and it is usually found in childhood. We spoke about the pigmented variant earlier, which is known as the Bettner tumor. And lastly, you can have a giant cell fibroblastoma, which is a juvenile variant. And in this variant, it presents as a dermal or subcutaneous mass on the trunk, thigh, and inguinal region. And it often occurs within the first decade, but may also occur in adults. So these are a few pictures from DermNet, and you can see for the first two pictures, it's from the same patient taken a year apart. And you can appreciate the plaque and later on the development of an exophytic nodule. And you can see another example on the right. What are the differential diagnoses of DFSP? For classic presentation, keloid or hypertrophic scar, dermatofibroma, fibrous histiocytoma, as well as nodular melanoma for the Bettner variant. For the atrophic presentation, it can resemble morphea, lichen sclerosis, or a morphiform BCC. What is the histopathology of a DFSP? Here you find dermal proliferation of monomorphous, slender or slightly plump spindle cells with little pleomorphism in a storiform pattern. You can also find the honeycomb pattern in which there is infiltration of the subcutaneous fat along fibrous septa, isolating adipocytes to form lucencies. There is often a poorly defined periphery, mitosis, and various patterns may include myxoid, neuroid, fibrosarcomatous, or granular cell types. Bettner tumor will present with the presence of melanocytes. So you can appreciate here the presence of your honeycomb pattern as well as the spindle cells. When the patients develop fibrosarcomatous dedifferentiation, these result in cellular tumor zones. And here you find a fascicular growth pattern, which is herringbone, fibrosarcoma-like pattern with p53 mutations, cellular atypia, and numerous mitosis. A DFSP is usually CD34 and vimentin positive, P75 positive with scattered factor 13A positive cells. The DFSP is usually negative for the following states: S100, SMA, desmin, keratins, EMA, and tennessine at the dermal epidermal zone. In terms of prognosis, DFSP is a low-grade malignancy. It infiltrates diffusely through the dermis and into the subcutaneous fat. It seldom metastasizes, but you can get multiple recurrent tumors and progression to fibrosarcoma. And the rare metastasis can occur to the lung more than the nodes. However, poorer outcome is associated with increased age, high mitotic index, and increased cellularity. 30 to 50% can recur locally after simple excision, and 5% transforms to conventional fibrosarcoma. Treatment of DFSP, the mainstay should be either with Mohs surgery, especially for slow Mohs, or standard excision with 1 to 3 centimeter margins. Adjuvant RT can be considered for patients with positive or closed margins, those with concern regarding the adequacy of negative margins, and if wide margins would result in functional or cosmetic defect. PDGFR-specific TKIs, such as imatinib or nilotinib, can be used in patients with advanced unresectable primaries or metastatic disease. Now, just a bit about slow Mohs surgery, which I do not offer due to logistic constraints. In slow Mohs, you need to use paraffin sections instead of frozen sections, and this means the specimen needs to be processed overnight in the dermatopathology lab. It results in better visualization, and the patient is sent home in the meantime with dressings in place until the results are read, and this may take a few days. And so with that, I thank you.